12 lead changes. Now, I know I said I'm not going to go over 12 leads. I'm not going to talk about EKGs, but you have to know what is causing your 12 lead change. What's going on here? We got a patient who's having an acute myocardial infarction. What is happening and why is that patient experiencing the symptoms that they're experiencing? Now, talking about a right coronary artery, also known as the RCA, you have to know this. Please write down what is supplied by the RCA. The right coronary artery, which on this diagram is that one over here on the left side of your screen. The right coronary artery supplies the right atrium, shocking, right ventricle, part of the left ventricle, which you see this thing like wraps a little bit around the heart at the bottom, and portions of the conduction system. And that's it. Right atrium, right ventricle, part of the left ventricle, and conduction system. Now, the larger of the two. This is the largest of the myocardial coronary blood vessels. Divides into the left anterior descending, okay, the LAD, and the circumflex. So it branches off into two other coronary arteries that are really popular that do get blood like stopped up or blocked with a clot. What it feeds in the heart is the left ventricle and the septum. The left ventricle is the big one. So if you have damage to the left ventricle, then obviously that heart's not going to be able to pump into pulmonary or throughout systemic circulation. Please know that is a 100% anatomy question. I can almost guarantee that everybody is going to have some sort of question off of those two slides on their national registry. And that's based off of coronary arteries. Now, what's the goal here? We're treating a patient with chest pain. We've talked about what causes angina, what causes unstable, or what is unstable versus stable. So if you know that lack of oxygen is what causes the pain, what is the goal? The goal is to get more oxygenated blood to the heart, period. We can all agree that's the goal. That's the goal for treatment. Now, if you were ever taught MONA, MONA stands for morphine, oxygen, nitro, and aspirin. Those are the four treatments that have always been talked about when it comes to chest pain. Is it still talked about? First off, yes, it's still brought up. Now, one thing that's interesting about MONA is oxygen. Prior, I can't even put a year on it, but several years back, we used to give every patient with chest pain oxygen. It was just like a standard. Oh, you got chest pain? We would start with oxygen. Remember, BLS before ALS, right? We would always start with oxygen. We no longer do that, okay? Understand this. Oxygen acts as a vasoconstrictor. And if you vasoconstrict, what are you doing to the heart? You're causing less oxygen to get there. Even though you're giving them oxygen, you can actually limit the amount of oxygen that you get to the heart because you're giving the patient oxygen. With that being said, should we be giving patients with chest pain oxygen? Only if they are hypoxic. Only if they're hypoxic. It's gotten so extreme that even in the American Heart Association, they're saying that even if we're only giving oxygen, just like with strokes, if the patient's SpO2 is less than 92, I believe still in the National Registry it's 94, but as long as you know, we're only giving the patient oxygen if they are hypoxic, not just because they have chest pain. Next, aspirin. Aspirin is a medication that we give to, it's called a platelet aggregator. Okay. What it does is it stops platelets from trying to clump up on each other. It's not a blood thinner, right? It's not an antiplatelet, but it kind of just makes them not stick as well on top of each other. Because remember, platelets, they kind of like crash into each other, then fibrin gets included, and then it creates this clot. But if your patient is on aspirin, those clots aren't readily made as easy, okay? That's the whole purpose behind aspirin. Now, it's interesting when we talk about the dose. One thing that I want to tell you about the dose is every single baby aspirin, like little pill that you're holding in your hand, is 81 milligrams. We give 2 to 4 baby aspirin to our patient. On a test, they are not trying to trick you. If they say 160 milligrams to 325 milligrams, the test is not trying to trick you. They're not trying to say, oh, we put the wrong dose on there. Let's see if the student No, how these tests are written, 160 to 325 is considered a normal dose. Even though I just told you each tablet is 81 milligrams, so technically it's 324 for 4. 325 is acceptable in the national standards, okay? Most tests that you're going to look at, they will say 325 milligrams. Do not think that the test is trying to give you a wrong dose, because that is the right right dose per testing when you go and take the test. So just understand that. 160 to 325 is fine. Next, nitroglycerin. Nitroglycerin is 0.4 milligrams, and that is per spray. Each spray goes under your tongue. We have to wait 3 to 5 minutes before we can give an additional spray. Per national standards, and this is the most updated, is we are still only giving up to 1.2 milligrams. That is the standard. Once you get hired somewhere, or some of you that are hired, your protocols might dictate that you can give more, okay? And that's fine, okay? That's what your medical direction allows you to do. But understand, as of right now, the standard for the National Registry is up to 1.2 milligrams. 3 sprays. Can we consider nitro paste? The answer is yes. If you carry nitroglycerin paste, we give that over the skin, right? Transdermal, and we do it over the patient's chest. Typically, you give 1 inch of paste, but nitro paste is commonly seen and commonly used for chest pain protocols. It's the same concept of giving somebody nitro, except now there's 2 different routes in which that nitroglycerin is getting into the patient. Again, very protocol dependent. Don't think that it's mandatory. Like, for example, if you're planning on doing the National Registry psychomotor exam and you don't say that you're going to use nitro paste, you will get points for using nitroglycerin, and that's fine. Morphine, starting at 2 to 4 milligrams, IV or IM, is the preferred analgesic for chest pain. The reason why it's the preferred analgesic is because morphine has vasodilation properties. If you give morphine to a patient that is having chest pain, and why analgesics work so well with patients with chest pain is because it actually reduces the amount of work or the amount of effort that this person's heart is trying to, basically, the heart's trying to work to stay alive, right? It's dying. So by giving somebody an analgesic, you actually take the edge off, and it makes their heart work less. Okay, it reduces oxygen demand. That's what we call it. Reducing oxygen demand is a good thing. Reducing preload, good thing, right? As long as the patient's blood pressure is fine, we're good. We're good to use morphine. We're good to use nitroglycerin as long as these blood pressures are good. But that is how we treat chest pain. We treat it first with aspirin, then we give nitro. If my patient still has pain after my first spray of nitro, let's say my patient's pain level was at an 8 when we started, I gave my aspirin. Believe it or not, aspirin's not going to make somebody's pain go lower, right? It's just reducing the amount of clotting that happens to hopefully don't make the clot worse. Then once we start giving the nitro and that starts opening up those coronary arteries, that's when their pain should start to reduce. Because remember, what did I tell you is causing the pain? Lack of oxygen. If we can get more oxygenated blood into the heart, the pain will go away. So by giving nitro, the pain should start subsiding. If we start giving that nitro and the patient still has pain, that is then when we will give analgesics. Preferably morphine if you have it. If you don't, can we use other analgesics? Absolutely. Something like fentanyl. Definitely a good medication that you can utilize to reduce the patient's pain. Remember, even though fentanyl is not going to really affect the patient's blood pressure or cause vasodilation, it will take the edge off of that patient and reduce the pain and maybe their anxiety. So it's a good thing. Do we have to max out on nitro before switching to pain management with an analgesic? No. Okay. As a paramedic, we can give a spray of nitro. Remember, now we're waiting 3 minutes, right? If my patient's pain's a 10, I'm not going to give them like a spray of nitro and I'm going to be like, come on, 1, come on, go down to 0, right? I'm not expecting the patient to go from a 10 to a 0 with 1 spray. So typically we'll start a line. I do not want to give my nitrates without obtaining an IV because God forbid, right? We give that patient a spray of nitro and then they bottom out. Now we're trying to fish for a line. It'd be a problem. So I'm going to get my IV. I'm going to give them the nitro. And if my patient's pain is severe, I'm going to start with an analgesic right off, right after giving my nitrates. I'll start with an analgesic, right? If I'm starting with morphine, I'll start with 2 milligrams of morphine on board. We're going to wait after my 3 minutes because I gave I'm going to have to wait at least 3 to 5 minutes for my nitroglycerin. I'll wait my 3 minutes. Hey, what's your pain scale now? Oh, it's a 4. Guess what? They're getting another dose, right? I'll give them another spray. Wait a couple minutes. If the pain gets worse or the pain isn't getting any better, I might consider giving them another 2 of morphine, or I might just attempt my last spray of nitro, see if that fixes it. And if it doesn't, then I'm going to back it up with more morphine. Our goal is to get the pain to a 0. That is ultimately the goal. Chest pain treatment. We talked about how we're treating it, but what's the hospital going to do? What's the hospital going to do? Can they give fibrinolytics? Sure they can. Ultimately, this patient needs something called a stent, okay? A stent. Now, a stent is also known as PCI. PCI is percutaneous coronary intervention. I would write that down. It must be done in a hospital setting within 90 minutes from door to balloon. What that means is as soon as that patient passes through the threshold into the hospital, they have a time limit in which the hospital must put a stent into that person's heart. Okay, it's 90 minutes for the United States. That's a national standard. And that's why, this is exactly why this slide, why we check 12 leads in the field and why we need to take the patient to the right hospital and why we need to tell the hospital what we have. We send them our 12 leads. We tell them, hey, we have a cardiac alert, we have a STEMI alert, and they prep the cath lab to perform a PCI. What's wild is if you see over here on the left side there, that little picture of what looks like fishing wire or that little guide wire, what it is, it literally looks like fishing line, and that they pass it through the patient's. They usually go around the groin area and they go up, and they basically fish this wire up into the patient's heart. They're using kind of like a Doppler or ultrasound to figure out where that guide wire is at, and they try to feed it into whichever artery is blocked. Now, they don't just look at a 12 lead and they say, oh crap, we have an inferior wall MI, so that means we have to go to the RCA. No, so what they'll do, they'll look at the 12 lead to determine, hey man, there's a block, we're suspecting it to be in this location. Then they're going to put a dye into the patient's IV. When they put the dye into the patient's IV, they can visually see with their instruments where the blockage is. So they're able to watch it on a screen. While they're watching it on the screen, they see exactly which artery is blocked and where it's blocked within the artery. That's when they're able to do the PCI, push that guide wire exactly where it needs to be. They put this mesh, which you see here on that photo, over to where that clot is, and then they inflate the tip of that mesh. It's like a balloon on the tip of it. The balloon opens up and it leaves a metal mesh that keeps it wide open. And once they do that, they're able to either dislodge or they'll suck out whatever that clot is to remove it from the patient's body. Okay. And typically when they do that, they're going to remonitor, still using the dye, do we have good blood flow? And if they have another clot, they'll go and put another stent. So typically if you hear somebody say, yeah, I had 2 or 3 stents put in, they had multiple clots or multiple blockages. Okay. And that's exactly what PCI is. Must be done within 90 minutes from door to balloon. What if they exceed the 90 minutes? Well, 90 minutes for one is a standard that the hospitals need to abide by. If it is less, or if it takes longer than 90 minutes, the hospital needs to explain why they were unable to perform the procedures within time. Okay. And the reason that it becomes a problem is, remember, the heart time is muscle. Your heart needs oxygen. Your heart's not getting the oxygen. There's been research shown that 90 minutes is an ample amount of time that the patient should be getting a stent within a hospital or cardiac facility. So these hospitals, they get a lot of funding. There's a lot of things that go within to make these time frames that the hospital has to use. So they have to meet them. Basically, it's for patient survival outcomes. It's as long as it's within 90 minutes, the patient has a greater chance of survival. Right ventricular infarct. If my patient has an inferior wall STEMI, I know, again, this is not me doing an EKG talk, but if my patient has a STEMI in my inferior leads, 2, 3, and AVF, we need to check for right-sided involvement. If my patient has right-sided involvement, this is known as a right ventricular infarct. Right side involvement, also known as a right ventricular infarct. What changes in our treatment? So Chris is 100% right. For us to check for that right ventricular infarct, we need to move V4R, right? Or our lead V4 into the right side. Okay. No nitrates gets brought up. Why no nitrates? Because remember, deoxygenated blood gets brought to my right side of my heart. The right side of my heart is where blood enters. That's where my preload is. Right? My preload starts on the right side of my heart. If I give nitrates to a patient that has a problem with the right side of their heart, a problem with their preload, nitrates lowers preload. So if I already have a problem with the right side of my heart, I'm going to have a decrease in preload. And then if I give them nitrates, it basically worsens the preload, even though it's already bad. Okay. These patients are very right side dependent on their heart. Their heart, the right side of their heart needs help. By me giving nitrates to a patient that has right-sided heart failure or right-sided ventricular infarction, I can cause a decrease in cardiac output, ultimately even killing the person and bottoming out their blood pressure. Okay, this is why we do not give nitrates to a patient with right-sided involvement. What changes our treatment? Obviously, we don't give the nitrates. Instead, we give IV fluids. We must give these patients IV fluids. Okay, we could start with a bolus of 500, and our goal is to maintain, again, preload. That is our goal with these patients. Maintain preload. Now, what if I can maintain preload by giving pressors? What do you guys think about that? What if I gave that patient like dopamine, or I gave them epinephrine infusion to increase contractility and increase rate? Do you think that's a good or a bad thing to maintain perfusion or maintain a preload inside of that heart? Do you think by me giving a pressor, would that be a good or would that be a bad thing? If the patient's heart is already dying and it has a lack of oxygen, and then you give them a medication that's going to make their heart work harder, it's just going to die faster. Ultimately, we do not want to make this heart do more work. We want to help this heart by just giving it more volume. Okay, again, we increase preload when patients have right side infarction. How will this patient present? This patient will present with a decrease in cardiac output. So we talk about cool pale diaphoretic in patients with shock, right? We talked a little bit about cool pale diaphoretic in patients with ACS. These patients will not only look cool pale diaphoretic, but their blood pressure will also be aligned with that look, right? Typically, just because you have somebody with chest pain doesn't mean they're going to have a low blood pressure. But if you do have a patient that has a low blood pressure and your patient looks not good, right? They look very pale, mottled, whatever the case might be. These patients that have right ventricular infarction, they present like that, okay? It's not uncommon to see a patient that looks like they are literally in shock, and then you put on a blood pressure cuff and you see that they have a low blood pressure. Then you find out that they have right side MI. We should never be giving these patients nitro. A lot of contraindications there, just blood pressure alone, right? Here's an interesting one. Takotsubo cardiomyopathy. What this is, it's called broken heart syndrome. I know, sounds strange. It's a heart attack caused by emotional stress. Typically, when we say broken heart syndrome, usually with Takotsubo, you see this in somebody who lost a loved one. So somebody whose heart's broken, they're so distressed, they're so stressed out by their loss, they're so sad, they mourn so bad that literally it causes a heart attack. Now, you might say, what the hell? What the hell is Takotsubo? This little diagram in B is a really old Japanese used to trap octopus, okay? It's called a Takotsubo. It's a trap that was made to catch octopus in Japan. Now, if you look in A shows the left ventricle of a patient's heart. And look at the shape of the left ventricle. Look what happens to the left ventricle. The top of it kind of goes like this near the closer to the atrium. And when you look at the actual apex of the heart, it gets really wide. So what happens to the ventricle, or to the chamber of the ventricle, it gets like enlarged with Takotsubo, and blood gets like, I'm guessing just because of the enlargement of that chamber, it puts pressure on the outer walls of the heart, limiting the amount of blood that's getting into the coronary vessels, and these patients die of a heart attack just from emotional stress. Pericarditis, viral, which is most common, bacterial or fungal infections that literally will cause a dysrhythmia in your heart and chest pain. So literally the pericardium that surrounds your heart, okay, becomes inflamed. Pericarditis. Pretty obvious, right? Now, the interesting part about this chest pain is it's not fixed with nitro, okay? It's not a lack of blood flow that's, well, can't say it's not a lack of blood flow that's causing the problem. Since that heart's becoming inflamed, it is technically a lack of blood flow that's getting to the heart. But by treating the patient with just NSAIDs, non-steroidal anti-inflammatories, you can actually reduce some of the pain that this patient's experiencing. Also, by positioning, having that patient with pericarditis lean forward reduces pain, okay? Don't have them lay back on your stretcher. Sit them up and make them lean forward. Now, typically with pericarditis, how we'll know is on a 12-lead EKG, we'll have a lot of ST segment elevation. And remember, concave versus convex. If they have a concave appearance within their EKG ST segment elevations, that is typically seen in early repolarization and in pericarditis. So that is typically how it's given away. Massive ST segment elevation in multiple leads, and it's in a concave shape. Viral pericarditis resolves on its own. Bacterial pericarditis must be treated with antibiotics, and fungal pericarditis is treated with antifungal medications. Now, obviously, these patients are going to require blood work to determine if they have a viral, bacterial, or fungal infection. So there's nothing you're going to do as a paramedic to be like, this is probably viral.